So now we'll start it with our pulmonology section. This will be the first one. We'll talk mainly about some pulmonology, infectious disease, you guys' favorite topic. And then in the next unit, or next section, we'll talk about asthma, COPD, and stuff like that. So first section here is going to be on more pulmonary antitussives / expectorants. So cough is, a pretty frequent complaint by a lot of your patients. We know that is due to a lot of either mechanical or chemical irritants. And so it's kind of a complex pathway that's going on here, this reflex that initiates a cough. And we'll see that some of the medications we're going to use are going to work directly either at the site of where the actual irritation is occurring or say up in the CNS in order to help prevent the cough from occurring in the first place. Obviously, some of the complications, I'm sure everyone's had kind of a chronic cough from illness at some point. It's pretty annoying. Insomnia, exhaustion, all kinds of bad stuff popping up here. Even some cases of history of stroke, syncope, rib fractures, even really bad stuff. Hopefully that should be pretty rare. So the idea here is our medications, we want to decrease either the number or severity of the coughing episodes and help prevent any complications from occurring. So one of the first drugs we'll talk about is going to be benzonatate, otherwise known as Tessalon. This will probably go down in history as one of the hardest drugs to dispense in a pharmacy because when you pour them out in the little thing to count to 5 and 30s with your butter knife, they roll everywhere. So very annoying to deal with. Anywho, kids like them because they look like little pieces of candy and they get into them and have issues. But anywho, so these work as an antitussive. They work by actually anesthetizing some of the stretch receptors in the lungs. And so by doing that, they kind of inhibit that reflex in order to cough, whatever that irritation is maybe leading to that. So pretty good agents for that. We'll kind of take it as needed several times a day potentially because it's a relatively short half-life. Big thing here is to let your patients know not to chew up the capsule because otherwise if it comes out, it'll end up causing the mouth to go numb. So that's one of the big things to let your patients know about. Just don't chew them. Other than that, not a ton of real adverse effects. One thing you can see with kids, if they were to accidentally get into it, it's not routinely recommended for them, but if they get into a lot of them, because again, they do look like candy, they can end up having some CNS depression related to the anesthetic effects kind of working up in the CNS. That can be a problem for some kids.
What are these called, Tessalon pearls?
Tessalon pearls, yeah, that's the name for them, yeah. The other thing we have is dextromethorphan. Lots of different brand names for this. This is an over-the-counter product, obviously. Robitussin, Delsum. Anyone know why I put a Bender on here, the robot? He does. Well, he likes to drink alcohol, but what do people do with dextromethorphan? Robo-tripping, yeah. It's not purple drink. That's Phenergan and codeine. Different stuff, not scissor. So robo-tripping is basically the process where you take way too much Robitussin or dextromethorphan in order to get high. So the way the drug works is it's actually a derivative of an opioid. So it's actually kind of similar in structure to something like codeine or morphine. Doesn't have any analgesic effects itself, but what it does do is actually centrally depresses that or suppresses that medullary cough center working through these sigma receptors. The other thing it does have is, have you guys ever heard of NMDA receptors? So they're a type of glutamate subtype of receptors. It actually has some antagonistic effects there. So something like ketamine actually works very similarly. So normally at regular doses, dextromethorphan doesn't cause a lot of psychoactive effects, but as you increase your dose, you actually can get more of that anti-NMDA effect. And so that can cause kind of a dissociative kind of high kind of out-of-body experiences. And so people can take quite a bit of this stuff in order to get to varying planes of existence, I guess. This is not from personal use, I guarantee you. I'm not dumb enough to abuse this stuff. It's not a very mellow high that can for sure. So again, it'll be and again, typically kids have a lot more time than they do wisdom at a young age. So and it's available over the counter, so they can get as much of the stuff as they want for the most part. But anywho. Certainly, if you were to take too much of this, you can see things like confusion, excitement, agitation, so even hallucinations in some cases. And then other things you want to worry about is there actually is some risk for developing serotonin syndrome with this medication. It's not really clearly linked to the mechanism, but if you have other serotonergic medications on board, like selective serotonin reuptake inhibitors, you can actually end up seeing some toxicity from this. Things like hypertension, tachycardia, hyperthermia, things like that. So just be aware that risk is there, and to let your patients know just to follow the dosing guidelines. If they kind of feel anything odd or funny, just stop taking it. Guaifenesin, we mentioned this before. I believe, again, this is just an expectorant. It works to kind of increase decrease the viscosity of a lot of those pulmonary secretions. Again, big thing here, just take lots of water in order to help kind of cough all that up. Okay, so moving into our antibiotics. So again, like I mentioned, it's so important to do ID first because it'll keep coming up over and over again. And so here it's good to have your good fundamentals so we know why we're using the drugs we're using for these patients. First thing we'll talk about is going to be bronchitis. So again, this is going to be mainly inflammation of the bronchi. Typically, you'll see it being secondary to some sort of infection, whether it be viral or bacterial in nature. Big thing here is not really affecting the bronchioles of the alveoli, so it's kind of a more upper level kind of infection we're seeing here. You'll end up seeing kind of acute bronchitis affecting patients of all ages, but certainly for your more chronic bronchitis, that's going to be more for your COPD type patients, right? So it's chronic obstructive pulmonary disease patients. You're going to see it being pretty common during the winter months, so we're coming up on that season now. Can kind of start off as more of an upper respiratory tract infection, then kind of become secondarily bronchitis that can occur. Cough usually occurs pretty early, maybe non-productive at first, but then it'll become more purulent as you go along, and it may or may not have fever, right? Certainly lung exam may show some stuff there, but typically if you look at a chest x-ray, you don't really see any alveolar involvement, so it's not really like a pneumonia from that standpoint. So causes-wise, you'll see that many of them are going to be viral in nature. So the problem with these cases of bronchitis is that most people get prescribed a Z-Pak, send it on their way, and then they're good to go, right? Well, a lot of these are going to be viral in nature. So unless you know that, or at least you have a suspicion that it's bacterial, you really shouldn't be prescribing anything for it. But your patients come in, they want a prescription, otherwise they feel like they got gypped at your visit, so you're going to give them a Z-Pak anyway, right? No, exactly. You're not going to do that. If it's going to be bacterial, you're typically going to see more mostly atypical, so things like Mycoplasma, Chlamydia, Bordetella. You can see some gram-positives here as well, so things like Streptococcus, Staphylococcus, and then gram-negative like Haemophilus can pop up potentially. Typically, you see the bacterial infections come kind of secondary to the viral, so viral infections kind of set the stage and allow the bacteria to kind of set up shop. Typically, because most of these are viral, there's not really going to be any medications we can prescribe to deal with the virus, but symptomatic supportive care is typically enough for these patients. So again, either giving analgesics, antipyretics, things like Tylenol, ibuprofen, things like that, antitussives, make sure to just taking lots of fluids. Some people feel that if you give them antihistamines, so especially first generations that are more drying in nature due to their antimuscarinic actions, you may actually end up dehydrating some of these bronchial secretions and may prolong symptoms. So they can't really clear it quite so well. So that's where something like that guaifenesin could come in and potentially loosen those up and allow them to expectorate it. Like we said, routine antibiotics are not recommended. This is a very, very common cause for unnecessary antibiotic prescriptions. But if they're having persistent symptoms, say over 5 days, at that point you may consider bacterial involvement. So I see a lot of providers, what they'll do is, they'll say, okay, this is most likely a viral. But to prevent you from having to come back in case it is bacterial, here's a prescription. Don't fill it, but if you're having symptoms after, say, this many days, then go ahead and fill it at that point, right? So that is one potential. Obviously, your patient, you're kind of trusting them to do by your instructions, which they may or may not do, but certainly that's a possibility. As far as medications go, because we're mainly focusing on those atypicals, you'll see doxycycline is going to be one of the big ones. Doxy is probably going to be becoming more in vogue because the resistance to mycoplasma to the macrolides is becoming more prevalent, mainly due to overuse of these medications. So doxycycline is certainly a big one. Who do not use doxycycline in? Kids less than usually 8, and then who else? Pregnant patients, absolutely. Otherwise, potentially macrolides could be used. So certainly, azithromycin will be the most common one. Z-Paks are super easy; just use it directed, and they got a script, and they're good to go, right? So those are very common ones. And then, if you're really worried about resistant strep pneumo, then you can potentially utilize a respiratory fluoroquinolone. So something like levofloxacin, ciprofloxacin might be available there. Again, you really don't want to overuse those medications because resistance is such an issue. But unless say they've been on multiple courses of antibiotics already, that may lead you to think that they're more at risk for having a resistant strep pneumo, in which case that fluoroquinolone might be necessary, right? So if they keep coming back, they keep having these recurrent symptoms, and the medications are not working, at that point you may consider something like a fluoroquinolone. All right, moving on to our community-acquired pneumonias. So obviously we know that the airway is typically pretty good about clearing away bacteria and things like that. Usually the lower respiratory tract should be a pretty sterile place for the most part because we have this kind of mucociliary clearance. It's just kind of constantly shuttling things out of the lungs. We know that microbes can enter via several different mechanisms. So certainly if you have aspiration from the oropharynx, so this is more common with elderly patients who maybe don't have really great control of their airway anymore. You can have inhalation of infectious aerosols, some hematogenous dissemination from a bloodstream infection, and then you can even have direct inoculation. So say you had trauma that could occur directly leading to the bacteria being kind of deposited into the lungs. You guys know the signs and symptoms, so certainly cough, fever, sputum, all that kind of good stuff. Best way to diagnose this is going to be chest x-ray, absolutely. But certainly there can be some other atypical signs. So like in your elderly patients, if you see mental status changes, infection should be one of the big things you're thinking about. Chest pain might be another one of those things that can pop up as well. So I mentioned, looking for signs of infiltrates on the chest X-ray is obviously going to be your golden ticket to diagnosing this. If it's one of those things that even the pharmacist can see, then it's probably pretty bad, right? Keep in mind though, your chest X-rays may actually look kind of normal, especially if you have immunocompromised patients who can't really mount a good immune defense. So something to just keep in mind. As far as outpatient management for community-acquired pneumonia, patients typically do pretty well with empiric antibiotics, and so you don't necessarily need to get cultures for that, right? Especially if the patients start the antibiotics, they're feeling better, you don't necessarily need to worry about that. However, if you're more worried about the patient, if they maybe are having, have failed previous therapy, something like that, certainly would be one you'd want to consider culturing. For hospitalized patients, certainly you want to consider culturing them, but you want to do it prior to starting antibiotics. And why is that?
Because you're going to wipe out some population.
Right, so if I give my antibiotics first, I can start to kill off those bacteria that may be the actual causative organism and make it more difficult for me to actually culture it out and grow to see what's actually causing the infection. So that's one of the big things there. Most of the time, if you're looking at sputum gram stains, they may not be super useful, especially if they have a lot of epithelial cells being seen there, because at that point, it's just kind of spit, right? You're not really getting a lot of the secretions down from the actual lower respiratory tract to tell you what's causing the infection. So a lot of times you can get contaminations of the culture if there's just sputum, but that doesn't really tell you a whole lot.
Would you start them on something broad after you got the culture until you get the results back?
So yeah, we'll talk about that. But typically, if you have your patients, you will start them on broad spectrum antibiotics. You'll get your culture, start them on antibiotics, and then at that point, once you get your culture results back, you'll scale back. We'll talk about that process in a minute. So again, sputum is not always going to be your gold standard there to determine what the actual bacteria is. Really, bronchoscopy, getting an actual BAL or something like that, bronchoalveolar lavage is really the best way to figure out what's going on. But obviously, it's more invasive. Lots of ways to determine how you should treat your patient. Should they be sent outpatient? Should they be kept inpatient? I'm not really going to go over that because it's a lot of CURB 65 scores and pneumonia severity index. It's not really germane to our discussion towards antibiotics, but just know that there's lots of ways to determine how you should kind of triage your patient, whether they should go to ICU versus the med-surg floor versus they should go home. So looking at causative organisms, we'll see that it kind of can change depending on if you're looking at the kind of where they're going, and this kind of goes back to the severity of disease that they're experiencing. So for outpatients, for someone who's looking relatively well that could go home, you're thinking things like streptococcus pneumonia, you're thinking things like mycoplasma, Haemophilus influenza, Moraxella, and so this is kind of a spattering of some minor gram positives, gram negatives, but also these atypical bugs that pop up here as well. So those are mostly your causative organisms. You're going to see your empiric treatment for outpatients are going to be geared towards those bugs. As you get into some of the inpatients, say like a non-ICU type of patient, still see very similar organisms here. You can start to see some other bugs that pop up. So things like Legionella, if you had an aspiration pneumonia, things like that can pop up. And then for your ICU patients, the bugs you're really going to start to be worrying about are going to be more of your gram-negative bacilli, so certainly things like Pseudomonas are going to start popping up, and then Staphylococcus aureus, so MRSA specifically. So if you have a patient who's going to the ICU, your coverage is going to be more broad because you're more worried about those type of bugs that are more virulent, causing your patient to be more ill, right? So how do you know if your patient is going to be at risk for resistant strep pneumo? Because this is going to be determining what type of antibiotic you're going to be using. So if their age is greater than 65 years old, if they have had a beta-lactam within the previous 3 months, that's going to make them more predisposed to developing a resistant strep pneumo infection. Alcoholism or immunocompromisation can lead to this, and certainly if they have a lot of medical comorbidities, so if they have diabetes, renal insufficiency, CHF, all that good stuff, can lead them to be more likely to have a resistant bug. And then also if they have exposure to a child who's in daycare, because we know that daycare is basically a giant cesspit, they're more likely to have resistant bugs as well. Looking at risk for enteric gram negatives, so certainly if they are residing in a nursing home, they're more likely to develop organisms from these enteric gram negatives. Underlying cardiopulmonary disease, because they probably will have impaired clearance of a lot of those bacteria, a lot of medical comorbidities, and then also recent antibiotic therapy as well can increase that risk. And then if you're worried about Pseudomonas, those patients would be ones that are having structural lung disease. If they've been on corticosteroids recently, because again that has immunosuppressant effects, so that can make them more likely. Any broad spectrum antibiotic therapy within the past 7 days of the month. Right, so for greater than 7 days during any time in the last month can make them more at risk, and then also malnutrition as well. So again, if they're not being nourished very well, they're not going to have as good of an immune response. So, looking at outpatient treatment. So if you have your patient, you decide, okay, I think you're good to go back home. Here's what I'm going to be treating for you. First thing, if they don't have any risk for strep pneumo, based on what we talked about. You can get away with using a macrolide. So certainly things like azithromycin, clarithromycin are going to be your go-to macrolides there. As a second line, if they had, say, an allergy, they could utilize something like doxycycline or minocycline, right? So I might have test questions that come up, say like, hey, you have a patient who comes to you, you decide they can be a good candidate for outpatient therapy of community-acquired pneumonia. They have no risk factors for strep pneumo. What would be a good broad or a good and pure coverage for that pneumonia, right? So you say, okay, well, it's probably a macrolide, right? Versus if I said something in the case history that said they have some risk factors for strep pneumo, so I might put they've received antibiotics 2 weeks ago and they're greater than 65 years old and they're alcoholic. Those things make you think, okay, they're more risk for having strep pneumo that's resistant, in which case you might need to kind of broaden your coverage more. So in this case, you'd actually use a beta-lactam plus a macrolide. And so what you can use is amoxicillin plus or minus clavulanic acid. So again, if they've been on amoxicillin recently, it probably would step it up and use something like Augmentin that uses that combination there. Or you could utilize something like a second or third generation cephalosporin. They'll have better coverage against strep pneumos resistant. So cefuroxime, cefpodoxime is a potential there. Or rather than that, you can use a respiratory fluoroquinolone. So certainly levofloxacin, moxifloxacin falls in that category. And that might be good for patients who have a legitimate beta-lactam allergy. You don't want to give cephalosporins or penicillins too. So that kind of makes sense. So you'd use a macrolide plus one of those, either beta-lactam or a respiratory fluoroquinolone. Preferentially, you want to use the beta-lactam though, due to resistance concerns. If you were to have inpatient treatment, this is where you're going to get away with using more intravenous beta-lactams. So you can utilize something like more third generations, like ceftriaxone, maybe potentially even high-dose ampicillin can help to overcome some of that resistant strep pneumo. Plus either oral or an intravenous macrolide. Obviously, you always want to use oral therapy whenever possible. It's much cheaper. Not having a line in your patient is always going to be preferential because that could be another source for infection. So here, you can use intravenous beta-lactam plus the macrolide or doxycycline or one of these respiratory fluoroquinolones we mentioned, right? And then in the ICU, kind of the same as the above, but you would end up starting all IV treatment because again, if they're sick enough to be in the ICU, they're going to need IV therapy. And at that point, you want to consider whether or not they need to be covered for MRSA, right? And so what's kind of our go-to MRSA drug? Vancomycin. So you're going to see a lot of vancomycin for these ICU patients. Okay. So patients who you think might have an MRSA pneumonia from the community, obviously there's going to be increasing incidence of this, but you want to suspect in patients who maybe have recently had influenza documented, or if they have these cavitary infiltrates. without risk for aspiration. So if you see that on the x-ray, that may lead you to think more MRSA. Or if you were to get your cultures back and you see high yields of gram-positive cocci in clusters, that could be another sign there. Typically, it's going to require vancomycin with linezolid as kind of a backup. Either there's an allergy or some reason they couldn't receive vancomycin, linezolid would be kind of your next drug. Remember, what drug can we not use for MRSA pneumonias? Starts with the D. Daptomycin, right? Daptomycin. Because that's the one that actually gets inactivated by the lung surfactant. So that would not be useful for one of these pneumonias. Okay, so for nosocomial pneumonias, so these are going to be pneumonias that they actually pick up while they're actually in the hospital or in some sort of healthcare setting. So again, this is an infection of the lung that's not present at the time of admission, typically say after 48 hours of hospital admission. Again, hospitals are great places to get sick, especially if you're in the ICU. Here you're going to be seeing that this is going to, when we talk about this, we're talking about hospital-acquired pneumonia, ventilator-acquired pneumonia, or healthcare-associated pneumonia. So if you see HCAP, VAP, or HAP, all those things kind of refer to these nosocomial pneumonias. We see it as fairly common. It's probably the second most common nosocomial infection after UTIs. UTIs are very, very frequent nosocomial infections in the hospital. And certainly, the more elderly your patient is, or the longer they've been mechanically ventilated, the more likely they are to develop this infection. Why do you think ventilated patients are at risk for these infections?
It's a big foreign in your throat.
Yeah, the big plastic tube in their throat. Like, of course, it's going to be a good vector for bacteria to start to colonize that and eventually get down to the lungs. So it's a direct vector for these to this protected site. So certainly, when these happen, higher mortality rates are definitely there, and then increased hospital costs. So even though you came in for one purpose, now you have all these secondary pneumonia that you're dealing with that extend your hospital stay much longer than you would be otherwise, right? So we see this a lot, especially in, say, like your surgical ICUs, where where I did my fellowship, we had a level 1 trauma center, and so you would have patients who come in and they're just whatever happens to be hip fracture or whatever type of injuries they have, and then they are in the ICU laid up for a while, and they get these secondary infections that prolong their stay by weeks to months. So it's a really big deal, and so there's a lot that goes into preventing these infections from happening in the first place. So a lot of things like mouth swabs, like chlorhexidine swabs, and things like that to help prevent these infections in the first place. So these healthcare-associated pneumonia, so these are going to be ones that are popping up greater than 2 days, or if they've been those that are at risk for this are those that have been hospitalized in an acute care facility for greater than 2 days within the past 90 days. So this includes like your patients who are in assisted living facilities and things like that, your nursing homes. If they've had recent IV antibiotics, they're going to be more at risk for developing this. Chemotherapy, because why chemotherapy? Makes them immunocompromised because you're knocking out their entire immune system, right? Wound care in the previous 30 days, and also a hemodialysis patient. What do you think hemodialysis patients?
Because they have to sit still all the time. They're not very energetic.
You have giant tubes in the body again,
Right, you have you may have a dialysis catheter that's in place, for long term. You may have, I'm trying to think of the word. Can't think of the thing, but sometimes we'll have like implants.
The fistula.
The fistula, there you go. First time I ever had to check a blood pressure in pharmacy school, this little old lady, she must have been like 9,000 years old. I had to go check her blood pressure, and I pumped up the cuff, and all I could hear whoosh, whoosh, whoosh. I was like, what the heck is that sound? She's like, oh, that's where my fistula is. And I was like, oh, thank you for letting me pump up this blood pressure cup right over it. She turned out okay. I think she lived for another 8,000 years after that. But anywho, yes, hemodialysis patients are very susceptible to infection, especially if they have indwelling, central lines and things like that to facilitate their dialysis.
Probably only 40 dialysis patients don't look good.
They don't look good, but man, they live forever. It's real hard to kill a dialysis patient. I say after all the bombs drops, like cockroaches and dialysis patients are left. It's true. Anywho, so looking at risk factors, there's some things you can change and some things you can't change. We'll talk about modifiable versus unmodifiable risk factors for these nosocomial infections. So things that are unmodifiable, so you can't change your age. So if you're greater than 70 years old, or say you have chronic lung disease, you're just more likely to get these infections. Depressed consciousness, so certainly if you're, say, sedated on certain medications that can certainly make you more at risk, or just your mental status is such that you've kind of progressed to that point of depressed consciousness. If you have a large volume aspiration, which can occur at any point, and then or if you're hospitalized during the winter months, these are all risks. Things that could change. Certainly, if you don't have to be mechanically ventilated, get the tube out. That's going to be one thing that can change. NG tube, ICP monitors. What is that? Anyone know?
Intracranial pressure.
Yeah, intracranial pressure monitors. You'll see a lot of like neurosurgical patients will have ICPs that are placed in. Again, that's a good site for infection. How about this? H2 blockers or antacid therapy. So we know H2 blockers are good for suppressing acid production in the GI tract. I haven't talked about this too much, but that's what they do. Why do you think that increases your risk for pneumonia?
And it doesn't kill things that get into your airway, into the stomach?
Yeah, so the bacteria that live in the stomach are normally being killed off by the stomach acid, right? The pH is such that it kills off most bugs there. So if I increase the pH by giving either an antacid or giving an H2 blocker or a proton pump inhibitor or something, now all of a sudden some of those bacteria can start to grow, and if they aspirate that, then that can lead to infection. So that's one of the big things that they worry about with some of your patients in the ICUs is that oftentimes they're on those drugs as kind of stress ulcer prophylaxis, but then on the other hand, you run this infection risk. So it's kind of a double-edged sword you're dealing with there. Certainly, previous antibiotic exposure and then reintubation all put you at risk as well. So looking at the bugs, they're most likely for nosocomial pneumonias. We're looking at gram-negative bacilli, so things like Pseudomonas aeruginosa, probably the most common ones we're going to be running into. E. coli, Klebsiella, Acinetobacter, all going to be big players here. Looking at gram-positives, certainly you're worried about resistant strep pneumo, but MRSA is probably going to be the more common one you're going to see coverage for. And then even you're worried about some fungal issues as well. So say you have an ICU patient you're treating with broad spectrum coverage of gram-positives, gram-negatives, they're just not getting better. Oftentimes they'll do fungal cultures to make sure there's nothing growing there you need to cover them for. And fungal cultures take forever to come back, but it's one of those things you need to do to make sure you can rule that out. So as far as treatment goes, obviously you want to start treatment as soon as possible. Don't want to wait for a definitive culture. You want to start with broad spectrum antibiotics, and then you need to consider whether or not your patient is at risk for multi-drug resistant pathogens. So we'll talk about what those risks are in a minute. And you do want to cover for MRSA and Pseudomonas. Okay. Once the culture results are back, then you can start to streamline your therapy in order to have less broad coverage in order to help reduce rates of resistance later on. So first off, you have your nosocomial pneumonia suspected. You have your HAP, VAP, or HCAP. Looking at late onset or other risk factors. So if they've had prior antibiotics, if you're suspecting colonization at any site, previous hospitalizations or chronic care, or if they're on immunosuppressives, like those are all things that make them more at risk for having multi-drug resistant bugs. If not, then you can use more limited spectrum coverage. Otherwise, you need to use broad spectrum coverage against all those MDRs, right? That's kind of the breakdown there. So if you have no risk factors for multi-drug resistant bugs, you can get away with something like a third generation cephalosporin, right? So it has good coverage against resistant strep pneumo, and it has some pretty good gram-negative coverage. Or something like a respiratory fluoroquinolone, like levofloxacin, moxifloxacin. If you're worried about atypical pathogens, that could be another good reason to use a fluoroquinolone. Or something like ampicillin sulbactam, which you guys remember sulbactam is what? That's a beta-lactamase inhibitor. Or we have ertapenem, which is what type of drug? I put it on the slides. Carbapenem, yeah. But this one's kind of narrow spectrum. So the big thing with ertapenem is it doesn't have Pseudomonas coverage. There's pretty poor Pseudomonas coverage. So that's why it's more limited spectrum here. If you think broad spectrum, then we need to, if you think multi-drug resistant pathogens, then we need to look at kind of expanding our coverage. So we can utilize an anti-pseudomonal cephalosporin. Does anyone know what one of those are? Cefepime is going to be your anti-pseudomonal cephalosporin of choice. Some of the 5th generations may have some coverage, but clinically what you see most often is going to be cefepime as your go-to. How about anti-pseudomonal carbapenem? Does anyone know any examples? Any of them except for ertapenem, right? So what's an example of one? Yeah, meropenem, imipenem is another good one, doripenem. And then anti-pseudomonal penicillin beta-lactamase inhibitor? Yeah, Zosyn, piperacillin, tazobactam would be your go-to there. And then plus a fluoroquinolone or an aminoglycoside. So the point here is why are we using 2 different drugs to cover for a gram-negative? Because we said we shouldn't double cover if we don't need to, right? So why would we need to here?
Well, these people are suspected to have multi-drug resistance, so you want to zap everything you can.
So yeah, so essentially these are like the sickest of the sick patients, right? As far as pneumonias go. So you, as long as you start these 2 drugs up, you're guaranteed to at least have something that should cover, especially if they have Pseudomonas. One of these drugs should at least cover that, right? So that's why you start off with 2 drugs here, and then we'll scale back. So it's not uncommon to see a patient who's on, cefepime plus gentamicin for a gram-negative coverage. Because again, if your Pseudomonas comes back resistant to one of those, at least the other one has already been treating that infection, right? And so aminoglycosides, which one would fall into that category? So what drugs would be considered an aminoglycoside? Gentamicin, tobramycin, amikacin's the third one there. That could be a possibility to use. So again, so you pick one of the beta-lactam basically, and then you have another type of gram-negative coverage. So usually either fluoroquinolone or an aminoglycoside. And then you need your gram-positive coverage for MRSA. So you can usually just get away with just one drug for this. And so vancomycin is probably going to be your go-to, right? Could you use oral vancomycin?
No.
No, right? It doesn't get absorbed, right? So that's for C. diff. So IV vancomycin. Although you could use potentially oral linezolid that does have a good absorption. But typically vancomycin is going to be your go-to. It's a lot cheaper than linezolid is.
These patients are that sick with pneumonia, they're probably not doing anything PO.
They don't do a lot PO. That's very true. So you do typically IV. And plus, if they're that sick, especially if they're getting septic, obviously your body wants to send blood to the heart and the head first, and so your GI tract usually gets kind of short shrift there, and so you have kind of impaired absorption, or at least run the risk of that. So again, looking at our anti-pseudomonal cephalosporins, really don't use ceftazidime. It's got too high a rate of resistance, so rarely do we use it for coverage for nosocomial pneumonias, but cefepime is going to be our big one here, right? And so if you keep in mind these patients are very, very sick, they could be septic, renal dysfunction is a very real possibility. So you're going to be monitoring renal function, especially if you get hypotensive and they're hypoperfusing the kidneys. You need to make sure you're doing your dose adjustments appropriately. As far as the carbapenems go, we'll have imipenem cilastatin or permaxin. Again, watch out for patients with seizure history, because we do know, especially those that have renal dysfunction, they can accumulate this drug, which can lead to more risk for seizures. Meropenem really doesn't have as big a risk for that. And then ertapenem is not going to be recommended here. Doripenem could also be used potentially as well. Again, these need renal adjustment.
Have we talked about cilastatin?
So cilastatin is actually, it's always compounded with imipenem. It's always going to be in combination with that. It's actually not a beta-lactamase inhibitor. What it actually does is prevent some renal toxicity from the drug. So. And then for anti-pseudomonal penicillins, I really only focus on piperacillin tazobactam. There's another one, ticaracillin plus clavulane, but that's not clinically used a whole lot. So Zosin's really the one you're going to be using here for this reason. Okay, looking at our anti-pseudomonal fluoroquinolones, so Cipro, probably not the first one you want to jump to, because it kind of has it's kind of more hit or miss coverage against Pseudomonas. So usually levofloxacin, usually moxifloxacin are going to be kind of your two go-to, right? Because we can't use moxifloxacin for what type of infections?
Urinary tract?
Yeah, urinary tract, because it gets metabolized in liver, but lung, it's totally fine. And the idea here is that the fluoroquinolones have good atypical coverage. So if you're concerned about that, these are good drugs to go with. They also have good lung penetration, and so lung penetration is a huge deal because if the drug can't get to the site of infection, it's obviously not going to be working all that well. So these have good penetration here, but obviously used judiciously, because rate of resistance is getting more and more as we go along, because they are very, very broad spectrum. And again, these are also going to require renal adjustment. Do you guys remember what cardiac effects the fluoroquinolones can have? QT prolongation, absolutely. So these patients might be on lots of other drugs that are prolonging QT as well. So you want to keep that in mind. So to make, check your EKGs potentially if you're really worried about that. If you're having lots of electrolyte disturbances, make sure you're considering all those points. Our aminoglycosides, so we already kind of identified all of those. Keep in mind that for this one, because these are bactericidal, because they have they're more concentration dependent killers, traditionally used to use every 8-hour dosing for aminoglycosides. We don't really do that much anymore. What we now do is these extended interval dosing, where actually we'll give it once a day. potentially even less if they have poor kidney function. But essentially, by giving one really big, huge dose, we know we're getting good, sufficient concentrations in the lungs in order to kill the bacteria off. And then you have that post-antibiotic effect that prevents further replication of the bacteria, and then you dose the next day. So the higher concentrations we can drive up there, the better. Obviously, the big things to worry about here is you need to do therapeutic drug monitoring to make sure they're clearing it appropriately, right? And that's where we're checking trough levels to make sure that they should be undetectable when we're dosing it once a day like this. And so you really need to check your renal function and make sure the levels are fine, because otherwise you run the risk of developing more nephrotoxicity and ototoxicity. And again, these are patients who are already kind of prone to nephrotoxicity as it is because they may be hypotensive and taking hits to the kidney from that standpoint. We have vancomycin. So again, this is going to be good empiric coverage for MRSA. Gold troughs here. We mentioned that the trough levels the gold troughs will change based on the indication. And so because, again, we want to make sure we have good penetration to the lungs, we're shooting for higher concentrations here. So the troughs that we should give for vancomycin should be somewhere between 15 to 20 micrograms per ml. If it was something like a septicemia, skin soft tissue infection, maybe 10 to 15 is okay. But for these guys, 15 to 20 for pneumonia penetration, this is it. Remember, don't check your levels too early. If I check it too early, is my steady state going to be falsely low or high? Low, right? Because I haven't had a chance to really build up to that steady state level yet. So if I check it too early, I'm going to think my level's too low, and that's I'm going to increase my dose, which may not really make sense for that patient, right? So if you wait till before the third or fourth dose, I know they're at steady state, and then I know that I can make good judgments based on that level. Obviously, looking at ototoxicity if the levels are accumulating, and then nephrotoxicity, especially on top of other nephrotoxins like aminoglycosides. Okay. As an alternative to vancomycin, we have linezolid or Zyvox. Again, this is good MRSA coverage. IV and PO forms are available, so this could be something that could potentially bridge them from IV over to PO therapy, which is always a good thing to do. And again, has good lung penetration, but very, very expensive. One benefit, though, it doesn't actually require any renal dose adjustment, right? So that's actually a good thing. But what's the other interaction you want to worry about with linezolid? The food, oh yeah, cheese and wine, right? So ICU patients probably should not be dining on cheese and wine, right? They're on the ventilator. But more importantly, what medication is going to interfere with? Selective serotonin reuptake inhibitors, right? So antidepressants are a big one because this acts as a monoamine oxidase inhibitor, so it can actually prevent the breakdown of serotonin. So usually the dietary interaction is not a big deal for your ICU patients, but certainly other medications that can interact there can be an issue. So further therapy, once the culture results are back, that's when you can start to scale down your therapy. So say, for instance, I have my patient I'm treating empirically, say they're on cefepime, say they're on gentamicin, and they're on vancomycin, right? And my cultures come back and it says, okay, it's Acinetobacter, it's only susceptible to meropenem. At that point, I would stop all three drugs and just switch over to meropenem. Or if it said it was susceptible to, it came back MRSA, it was susceptible to vancomycin, I'd stop all my gram-negative coverage, right? Because at that point, I know the causative organism and I can scale back therapy appropriately. Now, reasons to have failure of therapy, so if I'm giving the wrong drugs because of resistant pathogens, or if I'm giving inadequate coverage as far as broad spectrum, or the spectrum that I'm going for, could be a wrong diagnosis. Sometimes pneumonia is kind of masquerading as pulmonary embolus, could be a neoplasm I'm dealing with, and then also there's some complications that can occur afterwards as well. So certainly C. diff colitis can be a big issue, especially if you're on really big gun, broad spectrum antibiotics, begin to have empyemas and lung abscesses and whatnot. So typically, treatments say around 7 to 8 days. It'll be longer for some of these really resistant gram-negatives. So Pseudomonas, Acinetobacter, all those ones will be more, longer therapy.
If we order a sputum culture on an inpatient with pneumonia, are they automatically going to plant a fungal culture, or do we have to order that separately?
No, fungal cultures are different. They are, because your run-of-the-mill type patient is not going to be at risk for a fungal infection. So they take longer, they're expensive, so they don't do those routinely.
So we start off with a regular bacterial, and then
because
resistant.
typically you'll get like a gram stain back, and then you do a gram stain in culture. So they'll do the gram stain, you'll figure out if there's any kind of gram positives or negatives showing up immediately. Oh, not immediately, but within a couple hours. Yeah, and then several days later you'll have your culture results actually come back, right? So that's a big one there. Okay, so moving on. Next we can talk about tuberculosis. That was an interesting picture.
Christmas seals, oh my gosh.
Yeah. So anti-tuberculosis. So tuberculosis is something that's very, very difficult to treat because the bacteria causing it are very hardy, very resistant, right? So we'll talk about some of the different drugs we're going to use. A lot of toxic drugs, a lot of old drugs, but they're still effective for treating tuberculosis. So we know these are acid-fast bacilli, these mycobacteria. They have this very distinct mycolic acid layer. This kind of this waxy cell coat that actually prevents them and prevents a lot of drugs from actually interacting with them. Mycobacterium tuberculosis is obviously the one causing tuberculosis. It's very slow growing and can actually exist in these dormant states for long periods of time. So that's why you get TB checks probably before every rotation, I'd imagine. I felt like I got probably 12 PPDs placed during my rotations during time. I was surprised I did not actually test positive for it from all the tests they were doing on me. But anywho, so again, people can have these dormant infections and not actually be manifesting symptoms for quite a long period of time. And so what we see though, and this is something that will come up when we talk about chemotherapy drugs, is that a lot of these antimicrobials, they work best when the cells are actively dividing, right? So when you're actively trying to make new cell walls or actively trying to make new protein or DNA, that's when these are going to be working the best. And Mycobacterium is going to be something that doesn't divide all that frequently, and so it's going to be more difficult in order for our antibiotics to actually target these. There may be some that are fast growing, but the ones we're going to be focusing on today are more slow growing. So as far as duration of treatment goes, we saw maybe 1 to 2 weeks for a pneumonia. How long do you think we're going to be treating for these guys?
6 months.
Months, up to a year in some cases. We'll see some different instances where you need to treat for longer, but yeah, these are going to be more difficult to treat. So lots of different varieties. So certainly leprosy is a variety of Mycobacterium. The other one we'll focus on today primarily is going to be this Mycobacterium AVium complex, just because that's another good opportunistic infection we can look at that usually will affect patients with HIV or AIDS. So Mycobacterium tuberculosis, again, we know it's a worldwide problem. Probably around a third of the world population is infected, at least in that dormant stage, especially in outside of developed countries. Can exist, in dry sputum for long periods of time, spread through coughing, sneezing, etc. And it can, just stick around for forever practically. We also know that there's increased risk for resistant strains that are popping up, especially homeless patients that can happen there. Because if you imagine, if you're a homeless guy, treating your TB is probably not going to be your number one priority, right? So they can tell you you have TB. You have to take these drugs for 12 months, right? So one, can you even get the drugs? And then two, am I going to be actually compliant with taking them for that long? So they don't in some cases, and which makes them more likely to develop resistant strains. Because when you start to add that selective pressure against the TB and you don't finish out therapy and completely eradicate it, now you're just selecting out for more resistant bugs, right? So resistance to TB medications is becoming more of a big issue nowadays. Have you guys covered TB at all in your class? Okay, so you guys kind of know what's going on here, but you get these big, nice lesions within the lungs once they kind of activate after a period of time. Again, looking for our PPD, obviously you have that test conversion, so you can have that latent infection for quite a period of time, and then only about 10% or so are going to actually turn over and activate. A bird hit the window or something? Poor bird. So then, it's estimated around maybe 30 million active cases in the world of TB. So this is where you get, the weight loss and the, sweat, night sweats and fever, cough, and all that good stuff. Okay, just a picture of some lesions there. Okay, so how do we treat tuberculosis? So we're going to use lots of combination therapy. So we're going to be targeting multiple mechanisms of action in order to help eradicate this infection. So what you'll end up seeing is you actually do an initial therapy with 4 drugs, and then you'll actually scale back into a 2-drug regimen. And a lot of this has to do with the toxicity of the drugs, especially on a chronic basis. So for starting out, you'd use isoniazid, rifampin, ethambutol, and pyrazanamide, which most of these are new drugs we haven't encountered before. We'll talk about those in a second. And then you'd follow up with, say, 4 months of isoniazid and rifampin. So compliance is such a huge thing with this, and if your patients can't be compliant to it, you're more likely to run into risk of resistant bugs. So looking at, if you just had a pulmonary tuberculosis, it could be 6, maybe up to 9 months. If you had HIV patients who are immunocompromised and are not able to, mount an appropriate immune response, it could be treated up to 12 months. Say if it's more complicated TB and say it's affecting other body parts, even up to 24 months in some cases. So you never want to use single agents for this because, again, that just leads to more resistance. Okay, so the first drug we'll talk about is isoniazid, which is actually very similar to hydrazines, which, does anyone know what hydrazines are used for? Say like in Port Canaveral? Rocket fuel. You can actually see rocket. So this is actually a derivative of rocket fuel, which I think is kind of cool. Anywho, though, this is actually, you see that some of these drugs are going to be more bacteriostatic for latent infections, but once the Mycobacterium are actually dividing themselves, you're going to see that these will become bactericidal. And so this is actually going to be working by inhibiting that mycolic acid production, and so by inhibiting that waxy cell coat, you can actually prevent further replication of the Mycobacterium. Okay, this is going to be our first mechanism we're going to be targeting with this. Notice here that this drug is also acetylated, so this is also going to be affected by people who are slow or fast acetylators, which may lead to more toxicity potentially or treatment failure. So looking at the isoniazid, becomes metabolically activated by this peroxidase. Really the resistance that's going to be coming from here is actually changes in the mutation of the DNA coding for the activation enzyme. So the Mycobacterium can actually change the enzyme itself in order to make it so you don't actually activate the drug in the first place. So it's kind of like a prodrug not getting turned on by changes in the bacteria. Keep in mind, this one's actually good because if you had like a TB infection, say in the CNS, it says well absorbed, actually you'll be able to cover for that as well. So again, you can use potentially isoniazid for prophylactic use. It could be used by itself because again, it's going to be bacteriostatic in those latent infections. But in active disease, you do want to use it in combination therapy. So adverse reactions we can see very similar to hydralazine. You can see a lupus-like syndrome, especially in patients who are slow acetylators, right? Because they're not metabolizing as quickly, so they're going to build up in levels. The other thing you can see with isoniazid is actually hepatotoxic. So especially if you have patients who have hepatic injury, say they're alcoholics or they have advanced age, it's going to lead them to having more hepatotoxicity occurring in hepatitis. Another unique thing you can see with it, it actually depletes pyridoxine, which can lead to a peripheral neuritis. So whenever you're giving this drug, you always want to give pyridoxine or vitamin B6 along with it to help prevent that from occurring. It's kind of a unique thing with this drug.
Would you give this to patients' family members for prophylaxis? Or?
Not necessarily. Not that I've seen recommended. You're not like, you give like rifampin for meningitis prophylaxis. I've not seen that specifically, but.
So what kind of prophylactic use would you use it for?
If you're, say you're going into like more of an endemic area and maybe you wanted to help protect yourself against it, or depending on patient lifestyle and things like that, maybe warranted. And then the other big risk for isoniazid is CNS toxicity. So this is a really big one because it actually works to deplete GABA in the brain. We haven't talked much about GABA, but we know that's a major inhibitory neurotransmitter in the CNS. And so by depleting that, it's going to lead you to have a lower seizure threshold and lead to more seizures, euphoria, memory impairment, things like that. We talked about rifampin previously. We talked about it in which case? Yeah, endocarditis. Remember, what was special about when you should administer rifampin in endocarditis?
That's the third.
Yeah, you always want to do it the last drug because you worry about resistance popping up with that. So you don't have to worry about that with the rifampin in this particular case. But we know that it has lots of good coverage against different drugs, but resistance is kind of a problem for a lot of these. So we don't use rifampin. It's kind of a first-line drug for much of anything, but is used kind of as a standard in TB. Again, it's going to be inhibiting that DNA polymerase. It's going to form a complex with the enzyme. So fortunately, it's selective for the stuff that's in the enzyme in TB and not for ours. Again, rarely used by itself, but the primary use you'll see in tuberculosis. We mentioned in meningitis, you can actually give as prophylactic for family members if someone's had meningitis, and then in endocarditis, obviously. Adverse effects. We mentioned this previously, but this induces CYP3A4 enzymes, also to some degree CYP2C9, 1A2, but the big one's going to be CYP3A4, right? It induces these enzymes, which means it's going to drive levels of substrates of 3A4 down or up? Down, right? Because we're metabolizing it more efficiently. So this means that if you're on certain anticoagulants like warfarin, it can actually lead to more metabolism of the warfarin, thus you have less anticoagulant effect, can be a problem. Oral contraceptives can be an issue here as well. So keep in mind those drug interactions for your patients who are on other things. This also is going to turn all your secretions kind of orange to red color, so you can warn your patients about that. And then you can potentially see some flu-like syndrome along with this. Of course, they're having active TB, it's going to be kind of hard to differentiate, flu-like syndrome from this and versus, TB itself. The next drug is going to be ethambutol. This one is going to be bacteriostatic, and what we think how it works is that it actually inhibits the mycolic acid itself once it's made from being incorporated into the membrane. Thiambutal really doesn't have any other indications in being used for TB specifically, because it doesn't work against a lot of other type of bacteria. But basically what it's doing is by inhibiting this incorporation of the mycolic acid, you end up weakening that cell wall, and that allows other agents to actually get in and work a little bit better. So it kind of helps in that synergy kind of model. Thiambutal does need to be renally dose adjusted, so be aware of that. And again, you don't want to use it alone because resistance is going to be an issue here. Unique side effects that you see with this one, it's kind of interesting, actually decreases red-green discrimination, so it kind of induces some color blindness to some degree, and decreases visual acuity, which may or may not be reversible once you stop therapy. So again, it could be one thing to watch out for. Let your patients know that they're noticing visual changes. It may be a reason to switch up to a different drug potentially. Then we have pyrazinamide. This one actually gets converted over to pyrozinic acid, and it actually lowers the pH so that bacteria can't grow, and then they get phagocytized by the macrophages and can be processed. This is good because it actually helps to decrease the duration of therapy when used in combination with the other medications. We don't use it for too long, so we use it in the first 2 months to help avoid some of the liver toxicity. So you have multiple drugs on board that are potentially causing liver toxicity like diisoniazid, so this is why you end up taking this off after the first 2 months. And this one you do want to avoid in pregnancy. There are some birth defects that can occur there. So, if isoniazid or rifampin resistance, you do have to treat for a longer period of time. So again, that's something to note there. And then there's some other agents you could potentially switch out for, which I will not go into detail. Just be aware that there are other things out there that may have activity against TB, and these are good for like resistant cases or in cases where other drugs cannot be used. So you can see things like linase, lid, some of the macrolides or quinolones could potentially be used, but don't focus too much on that list. Looking at Mycobacterium AVium complex, we can see this is mainly something that will pop up in your immunocompromised patients. 10 to 40% of HIV patients may be infected with this, especially as their CD4 counts drop, and especially when they get below 100 cells per millimeter cubed. Most often this is going to end up causing a pneumonia, so if you're here like MAC pneumonia, this is what that's referring to. Typically the treatment is going to include things like rifabutin, which in your mind you can kind of think of very similar to rifampin, kind of in the very similar category, very similar side effects where it can discolor body fluids and can induce CYP enzymes. That's a thing to look at there. You could potentially use clarithromycin, obviously that's going to be a macrolide, or using something like thiambutal plus azithromycin. Other agents you may potentially see used include ciprofloxacin, rifampin, things like that. This one again, because the patients are typically immunocompromised, you do need to treat for a longer period of time, so say 16 weeks in this case. And if you ever see, say, like an HIV patient who's on azithromycin for an indeterminate period of time, most often this is due to prophylactic use to help prevent MAC from getting infected with that. Okay, let's see how much time I have. 9 minutes. I'm going to hold this and go ahead and let you guys go, and then we'll finish up with this, and then we'll have the, I think the hematology section is going to be the next one, and then we'll finish up with the review. So any questions on the material we covered so far?
I do. For these last two that we mentioned, the ones that are both caused by Mycobacterium, the TB and the MAC,
Yeah.
what's like the biggest difference between the treatment? Because aren't we just treating the Mycobacterium infection, or?
Well, they're two different bugs, so they're going to have two different treatment, as far as options go. So you saw like on the TB, you had to start off with that 4-drug regimen, and then you switch down over to the 2-drug regimen, versus something like the Mycobacterium AVium complex. You can get away, say, using like the thiambutal plus, clarithromycin or azithromycin for 16 weeks. So it's going to be, when you're doing treatment, it's going to be usually for a shorter period of time, but it's different drugs you're using. Yep. Yes.
Mm-hmm. And you said that for patients that are at risk for strep pneumonia, that you use a beta-lactam and a macrolide.
Mm-hmm.
Underneath it said it had augmentin and like cefuroxime. Do you also put a macrolide with that?
Yeah, so that'd be your beta-lactam, and then you'd add a macrolide to that. Yeah.
Okay.
Yeah. Any other questions? All right, well, I'll see you guys next time.